point where we can't handle all of those patients that are going to be depending upon us in order to get better. That situation is particularly challenging in our intensive care units. So as we enter this new year, our ICUs are still operating at nearly full capacity, and there's little room left if we were to have a surge in patients. I'd like to introduce now Natalie Crawford, intensive care unit nurse from I'll turn it over to Natalie now to talk about her work caring for COVID patients and managing this volume of cases.
Hi, my name is Natalie. I'm an RN here at ICU at St. Joe's Hospital, Lake St. Louis. I appreciate this opportunity to speak on behalf of the nurses that I work with, but most importantly, my patients who have lost their battle to COVID. As a nurse, I take pride in getting to know my patients, hear their stories, show them and their families compassion and professional care. But through COVID, I have found my work as a nurse has gone beyond medicine and critical thinking. These patients come to me in the ICU. They are gasping for air, breathing 40 times a minute, often struggling on CPAP with oxygen levels running dangerously low. They are uncomfortable. They are struggling. They are scared. They have already been in the battle of COVID for weeks, sometimes upwards to a month. So they are weak. Their families are torn. Most of these patients are honestly in their 50s and 60s. They know what's going on. And that leads me to discussions that we have with those patients. Once in the ICU, hard discussions take place. After very briefly introducing myself as their nurse, we get right to the point of, do you want a breathing tube? Do you want life support? Do you want this for yourself? And unfortunately, these conversations start too late in the process. You see, waiting until someone is in a full-blown panic, trying to stay alive, it's not an ideal time to have a rational decision. Many family members and patients opt for the breathing tube. Please do everything for my loved one. So the sedation is started. We intubate. We usually have to paralyze these people. Pressors are started. This involves feeding tubes, catheters, lines, dialysis, and they start to get weak over time. Organs start giving, complications of pneumonia, possible clots, strokes, heart issues. Their lungs get stiff. Pneumos are not uncommon with the amount of air that is being pushed down into these patients' lungs, just to, at best, get SATs in the 80s and 90s. Ultimately, through all of this hard work, they usually pass away. Their families struggle to understand how their loved one come into our ER with maybe a fever, shortness of breath, weakness, and now we're on the phone telling them that they're dying, that there's nothing more we can do. They continue to go downhill. As a nurse, it is absolutely heartbreaking. It's defeating work. Our job is getting harder and harder. We are getting stretched thinner and thinner, and we most of the time work for the exact same result. We are tired, we are drained, both emotionally and honestly spiritually. We are constantly grieving, not at work because there is no time for that. Once a patient passes, it is hurry up and do postmortem care. Bag that body, that person, and get them out of the unit so that the room can be cleaned stat, because that room is already being spoken for, and it's not always just by one patient. A lot of times there are patients in our ICU that step down that are struggling, as well as just out on the COVID unit that are well deserving of that ICU bed that is now cleaned and ready. So as a nurse, you're grieving with that family, and then once the patient passes, it's immediately on to the next admission, and we are starting all over again. That same person, different person, but the same scenario, rolling through those doors, not breathing well. Do you want a tube? Do you want life support? And the process starts all over again. It's hard to see death after death after death. And, to think that I am the last person that talks to this person, looks into their eyes, and hears their voice. Those families aren't getting those moments, and it's just me behind all of this PPE. Who my heart is breaking. I have a good poker face, but at the end of the day, I'm only human as well, and it's heartbreaking. And also just the phone calls and the updates to the family, because they are desperate to hear any type of good news. A lot of times they cannot grasp what's happening. This is a foreign language to them as far as the ICU, what we're doing for their loved ones. And it's very hard for them to wrap their head around it. So, they're calling me, "Hi, Natalie, any updates?" And I'm painting such a great picture for them, trying to let them see that it's not probably going to be a good outcome. And that's very hard. So behind these numbers that we see on TV every day, I feel like we're getting numb to those numbers. I feel like those numbers have more political meaning than they do a heartfelt death number. And I just want so badly for the public and anyone that has any position in this at all to remember that these numbers, they are people. They are people that have meaning, and they still have meaning even though they've passed. They had purpose, they had life, they had love, they had family, and now they're gone and stripped of it all because of a virus. And that leads me to two stories that I have a lot of stories, but these two really stick out to me in comparison of how these patients ultimately passed because of COVID. So the first gentleman was, he didn't have a bunch of comorbidities. He was a normal, your average 50-year-old man, and I didn't get a good chance to know this gentleman. It was my first shift having him, although he had been in our ICU working very hard to breathe on a CPAP for days and days. Come to find out, his wife was down the hall on the COVID unit, and she was doing better than he was. He made his way back to the ICU. So I walk in, introduce myself. "Hi, how are you?" And he looks at me with, he was mad, he was aggravated, and for lack of better words said, "I am done. Take this mask off of me. I'm ready to die." And that's how we met. And I said, "Are you sure? If you take this mask off, you're doing okay with the mask on, but if you do take this mask off, your stats go low. You're going to pass away if you take the mask off." He said, "I know what I'm saying, and I'm ready to die." So I tried to get him through the morning. He so desperately wanted something to drink, something to eat. He wanted pudding. He was so set on eating pudding. And I said, "Okay, well, we'll try." Well, as soon as you barely took that mask off of this man, he was down in the 60s. It was not a pretty sight. He was working very, very hard to breathe. He was tired. So I went down and talked to his wife, who, she's all excited to see me. How is he? How is he? And I said, he wants to pass today. And it's just such a crazy position to be in. No amount of nursing school or, I never thought I would be talking to two spouses trying to get through this day and navigate that one of them is ready to give up and wants to pass away, and the other one's so excited to hear an update from, about him from the nurse. Of course, this brings her to tears, and I'm in tears as well. So she says, well, I want to see him. I need to see him. That is my husband. I said, okay. So I talked to him. He says, no, she's not seeing me like this. I'm ready to go. And he, at this time, was very aggravated with me. And that is such a terrible, terrible place to be in, thinking, here I am. My only job is to be there for him and through these hard times. And that ultimately I'm helping him pass away today. That is my new hat for the day. And trying to get her through this as well. So we got his kids on the iPad to say their goodbyes, and the goodbyes are terrible to have to listen to. I say terrible because they're gut wrenching. You can place yourself in those kids' positions. I mean, this gentleman's my dad's age, so of course I'm trying to hold it together, but there's a human aspect to this where you can't hold it together all the time. And just you were a good dad, you were a good son. I'll see you in heaven. That's the things that we hear all the time. I'm sorry. So you have somebody that completely knows where he's going. He's confident in that and what he's done with, and he was done with COVID. We played music on his little radio. He had some gospel music he wanted to play, so we turned that on, and he held my hand and he said, "You promised me I don't wake up." And I had to tell him, "Yeah, I promise you won't wake up." And we took the mask off and we played our music, and he got his bite of pudding and he passed away with me in the room with him. Who, I had barely met this guy, yet we went through so much that day together, so many emotions. And here I am, Natalie, I'm in all this PPE. I'm very distanced from him because I'm in so many layers. That takes away from your human connection when you're, behind all of these layers. He really never even seen my face, So a man that passed away with his dignity. He did not want to be intubated. He got a final say in what he wanted. He got to do what he wanted. But nonetheless, a heartbreaking story and a very, very, very hard day for everyone involved. And a second patient that she come over. And same scenario. It's always about the same scenario as far as how these people present. And she was on CPAP, working very hard to breathe. She also had a pneumo where air was leaking out around her lungs, and just from the pressure of that CPAP. So she's miserable. That she's been working really hard. And she knew that coming over here, if she took the mask off, she would pass away. And if she got intubated, she was well aware of her chances of survival. And I would want to say she was around 60. And I went in there and, I talked to her about it, and she was she was very different from him in this fact. She could not make that decision. She said, "No, I have to get intubated." She said, I know I'm going to die. She said, "But I cannot make this decision." She said, you just put me in a coma, and you put the breathing tube down my throat." And she was crying, and she was scared. She was so scared. And she said, I know I won't make it out of here, but they told me that I wouldn't be here any more than 2 weeks. And I said, yeah, about 2 weeks is when we would try to get a trach, if you would want a trach. And she said, no way. I am not getting a trach. She said, I know where I'm going. She said, I know I'm going to die, but I can't make that decision right now. So it's again, I'm the one standing there talking to her, looking into her eyes as someone's telling me that they pretty much know what's going to happen to them. So when it was time to come in and push the sedation and do everything, we prayed. I brought Chris, the chaplain, in, and we prayed, and we held hands, and she put her arm out, and that really bothered me. I don't know why, but when I went to push the sedation to intubate her, she put her arm out, to get IV access. And it was just like her giving her body up. You're giving up so much of your privacy and your dignity by it was like she just gave up, and she died 3 days later. So she did not suffer for 2 weeks. She passed. But in comparison to those two people, the outcome was the same, and they both had a say in how they passed. And I just want people to know that those are just two stories. I could go on and on and on. But there are families that are broken. There are horrible decisions being made in the background that people do not understand. When they hear of a death, they think, okay, somebody passed of COVID. But people aren't just passing of COVID. They are fighting. They are struggling. They are sometimes going out kicking and screaming. I mean, they're scared. They're confused because their oxygen levels are at ridiculous levels. And families are having to make such there is just very hard decisions being made. And us nurses, we're not the victims here. I get that. These people are the victims, but we are definitely human, and we are definitely grieving. And like I said, we're not grieving at work. There really isn't time for that. But on the sidelines, this is affecting us in a bad way. It's hard to just turn that off when you have days like that, and you see those people's faces when you go home. You can't just erase these conversations and these emotions and feelings. So, the nursing staff, we are taking a hit as well. On top of these patients are coming in sicker and sicker. It seems like throughout these last 8 months, the acuity of these patients they're coming in really bad ways. So, I thank you guys for giving me this platform to share these stories. I'm sure my patients that are now in heaven and have lost their battle to COVID, I'm 100% sure that they're happy their stories can be heard and possibly impact anyone out there that has the slightest doubt of these numbers, or that COVID is real or it's not real, because previous to these days of them coming into the ICU, these are normal functioning people. You got to think about it. It's a virus, so it's very hard to imagine. And you hear these families talking about, we were just together and I just seen them and now they're gone. It happens that fast, and it can turn your world upside down. So that's where I will lead off. I appreciate you guys though very much. Thank you to everybody for giving me this platform to speak. So thank you.
Thank you, Natalie. We really do appreciate you taking time out to share your stories with us, and for sharing your stories about everybody that you work with and all those other healthcare workers that take care of all these patients. So thank you very much for that. Okay, so now we're going to go ahead and take a look at our numbers for today. And as we always do, we start off with our new hospital admissions. So this is the graph looking at hospital admissions. Again, it's delayed for 2 days, all COVID positive patients. Our daily admission that we're reporting today is 98, and that brings our rolling 7-day average up to 102 admissions per day. again, still at an extremely high level. I know we've come down from that peak of around 150, but still, anytime we're admitting 100 patients a day to our hospitals is just way too high. Moving on to our hospitalizations today. Today we're reporting 830 patients hospitalized with confirmed COVID. That's compared to 865 that we reported on Monday. And the moving average now is 832 patients in our hospitals. Again, still very high number. A little more detail on our numbers. Again, these are all COVID positive patients. As I said, we have 830 patients in our hospitals today that are COVID positive. We have 176 patients in our intensive care units, and that compares with 172 yesterday. And we have 112 COVID patients on ventilators today, and that's compared to 107 from yesterday. Looking at our suspected COVID patients, again, these are patients where we're waiting for a test result to come back. Today we're reporting 70 patients in our hospitals with suspected COVID, 10 suspected COVID patients in our intensive care units, and 5 on ventilators. Move on to our good news slide, our discharges. To date, we have around 14,462 patients that have been discharged from the hospitals since the beginning of the pandemic, and we discharged an additional 140 yesterday. So large number, but again, we have a large number of patients within our hospitals, so we should expect those large numbers to be discharged as well. Unfortunately, we had a bad day yesterday in terms of number of deaths. We had 25 reported deaths from COVID yesterday in our task force hospitals, bringing that 7-day average up to 17. And again, just to reemphasize that these data are all related. As cases go up, our admissions go up, our hospitalizations go up, and unfortunately our deaths will go up as well. And so until we get those number of cases down, number of admissions down, hospitalizations down, it'll be very difficult to get those number of deaths down as well, as you heard Natalie talk about all of the very difficult times in the intensive care unit where she works. So today we're going to highlight our scorecard. So this is a scorecard that the task force puts out every day. So we'll just take a look at some of our metrics that we use. As you can see here, this is a percentage of COVID and patients under investigation as a percentage of our hospital beds. So today we're reporting around 18.5% of all patient beds are being occupied by a patient with COVID or is under investigation for COVID. The more challenging number is the one below that, which is that 26.5, which is our intensive care unit beds. So you can think of it as 1/4 of all of our intensive care unit beds are occupied by a COVID patient or a patient under investigation. Now that has come down somewhat. I think last week we were around 30%, so that's good that it has come down, but still much too high. We've already reported on our new admissions, so I'm not going to spend any time on this slide. Our prevalence of reported cases, so again, this is the prevalence of disease that's out in the community. It has come down some, which is good news. We're reporting around 7 per 1,000, or if you move the decimal point back, that's about 0.7 per 100. So we're still close to that 1 per 100 mark, but it has been coming down, so that's good. And our weekly change in new cases. So again, this is a 14-day rolling average where you take the last 14, you subtract it from the previous 14 and look at the difference. And we are at a minus around 20%. Some of that might be artifactual from the holidays because, of course, we don't do as much testing over the holidays. So we'll take a look and follow those trends over time and see if there's any rebound from after the holidays when we believe testing will probably pick back up again. Our testing percent positive is still very high. It's hovering right around 20. It's been consistently there for a little bit of time. Still much too high. We want this below 5%, so 20 is much too high. And then our transmission number is around 0.81. Of course, we calculate that based on our census and our cases, so we have been trending down. So that is good news. But again, it's dependent upon some of the data that we feed into it. And so we're hoping that those number of cases stay down, the admissions continue to trend down, and the reproductive number stays lower. But we'll be following this over time once we get through the holidays as well. So as I said on Monday, this pandemic is not going to end just because we are entering the new year. The situation in our hospitals is not going to improve just because we turn a page on a calendar. Now, there is reason to be optimistic of what the new year will bring, especially with vaccine and with more immunity in the population, but we're not there yet, and it's going to take some time to get there. There's no question about that. So while we wait and see what the impact of our Christmas gatherings and travel will be, we need to stay vigilant and do what we can to keep the number of COVID hospitalizations from climbing any higher. So please be smart about how you ring in the new year. This is not the time to be celebrating in a crowded space like a bar or in a crowded space like a home full of friends where the virus can easily spread. So please, this year, stay at home, stay safe, and have a happy New Year's Eve with the people that you live with. And with that, let's look forward to a better 2021. So now we will take some questions from the media.
How is COVID-19 different from past flu seasons from a hospital and ICU capacity standpoint?
Yeah, that's a good question, and it's one that we get fairly frequently. At least we've heard people discuss this, and we've heard other people's opinions about this. So we went out and we looked at some of the data. So we're still compiling the data here locally, but there's a couple of good articles out in the literature that really highlights the difference between COVID and influenza. So one of those I put up here, and this is from Time Magazine, and it's a very recent article. It's from December 17th, and it was looking at what is the difference between COVID and influenza. And I'm just going to highlight a couple of things. We're not going to go through the entire article, but a couple of graphs that were put together. And so one is hospitalizations. So as you can see on this graph, when you look at it per 1,000 people, COVID is far and away has hospitalized many more patients than influenza has, really since probably the 1918 pandemic. Now, you see there in 2018 where we had a particularly bad flu season, and COVID has blown way past that as far as hospitalizations are concerned. So there's really just no comparison between COVID and influenza, particularly in a normal influenza year. It's 3 times higher. You can see this from this graph. So there's no doubt that COVID is hospitalizing more patients than influenza ever has. But I think this one is even more important, and this is looking at the number of deaths. So as a percent of the total deaths that are occurring in the United States, COVID occupies a large percentage of those deaths, whereas influenza does not, usually around 4% per year. But COVID, as you can see here, can sometimes go up to over 20% of our deaths across the country. So there's again no comparison when it comes to the lethality of this virus compared to influenza as well. A couple of other graphs just to show you really quickly, because I know we've spent a lot of time here. But this is from a study out of the St. Louis VA. A couple of researchers there looking at influenza compared to COVID. And I'll just highlight some of these here very quickly. And so this is admissions to intensive care units. And as you can see, as what's called an incidence, so that you're tracking the number of people that are going into the intensive care unit, again, no comparison to influenza on an order of magnitude higher than influenza patients. Mechanical ventilator use, same thing. Just huge percentages more than our influenza patient population. And then lastly is deaths as well. And as we highlighted with the CDC data, the deaths from COVID far exceed anything from influenza. And so if we look at this in a table format, I'll just briefly explain this to you. In ICU admissions, what's called a hazard ratio, which is if you have COVID, you're about 2.5 times more likely to be in the ICU than if you had influenza. And this was looking at 3 years worth of influenza data. If you have COVID, you're 4 times more likely to be on a ventilator. So as you heard Natalie talk about putting people on a ventilator. And then you're almost 5 times more likely to die if you're admitted to the hospital with COVID than if you were with influenza. And not only that, your length of stay is longer, so the burden on the healthcare system that you've heard us talk about repeatedly is that much more. The average length of stay for a COVID-19 patient is around 3 days more than for the typical influenza patient that's admitted. So there's no comparison to it other than they're both viral respiratory pathogens. And that's really where the similarities end as far as hospitalizations, intensive care unit, death, all of those things. So I'm hopeful that we can put that argument to rest because really there's just no comparison between COVID and influenza.
National news outlets report the pace of vaccinations is very slow. Locally, is there a vaccine bottleneck, and if so, what is causing it?
The challenge that we're having with vaccinations right now, so it's not that we don't have people to vaccinate. We're delivering vaccine to our healthcare workers virtually every day. The challenge has been the amount of vaccine and the timing of when we're going to get delivery. So it's very difficult for us to plan going forward when we don't know week to week how much vaccine we're going to be receiving and when we're going to be receiving it. And so I'll give you an example. Last week, we at SSM received what we asked for in terms of amount of vaccine. This week, we didn't receive any vaccine. And so, and next week, we believe that we're going to start getting the second dose from our earlier vaccinations, but we're unsure of what other doses we're going to be getting. So it's a very challenging logistics project. I think you have to remember that this is the biggest vaccination campaign really that this country has had to deal with. And so there's a lot of challenges with that logistics of getting vaccine. When are we going to get it? How much are we going to get it? All of those things, and that makes delivery that much harder.
How much help are local hospital systems getting from the Missouri Department of Health and Senior Services to create the vaccination infrastructure needed for the COVID-19 vaccine rollout?
Well, so the Department of Health and Senior Services have given us their playbook, and we've been using that to develop our vaccination campaigns. It's as you would expect with this large vaccination campaign ongoing. There's going to be hiccups in it, but we have our team together that's working through the playbook that the state has given out. We're trying to build our infrastructure and how we're going to be immunizing those different populations. Starting off with the healthcare staff, and then moving to essential workers, and then eventually to other people at risk, and then eventually to the general public. But this is a huge effort, and so we're still building the plan.
How many vaccines have been given?
So we're estimating that we've given around 33,000 vaccines out to healthcare workers throughout the Pandemic Task Force here in the St. Louis metropolitan area. And so that's between the 4 different healthcare systems, but right around 33,000.
Outside of hospital staff, are people in private doctors' offices going to be fast-tracked to get the vaccine?
Well, it depends on what you mean by fast-tracked. So the CDC put out their tiering schedule on who takes priority for vaccinations. And so, as many of you know, it goes from 1A to 1B to 2 to 3, and then depending upon where you fall within those buckets. So primary care providers, again, there's even different tiering within that group, I would say. So there are certainly physician groups and clinics that are treating COVID patients right now that are at higher risk than other physician groups. So think about things like orthopedic surgery, where there's low risk of COVID exposure. And so they are in one of the upper tiers, those primary care offices and those those providers that are outside of the healthcare systems. But we're still trying to work through all of our healthcare providers in the hospitals before we can get to some of those other healthcare workers that aren't inside the hospital. But definitely they're in the upper tiers. It's just trying to work through delivery.
When will we see a vaccination plan for the region?
Still being developed. I think it's still going to take a little bit of time working through the what the state has given us, trying to understand capacity, trying to understand how much vaccine. The good news is that local health departments have been working on mass vaccination campaigns for quite some time. So we do have a sort of a playbook that we can use. Now we just have to adapt it to the situation at hand.
When can first responders expect to receive the vaccine?
Yeah, another good question. First responders, are again a high priority population. They probably should have been in that 1A group, in that highest population, but they're not, and that's unfortunate. So we're looking at ways where we can get them closer to the front of the line because they are dealing with these COVID patients as well, and many of them are being exposed. And so as soon as we can work through our healthcare population, we want those frontline workers, those EMS workers, to be higher priority as well.
St. Louis County today announced it is relaxing restrictions to allow for limited indoor dining at restaurants. What does current data indicate about COVID-19 cases in the region linked to indoor dining at restaurants?
Yeah, so we don't get the data for exposure. That's all health department data. And so our recommendations are strictly based off of what is really standard public health measures to prevent spread. So anytime you're in an enclosed space and you're not able to wear a mask, you're at increased risk for exposure. But as far as the data, that's something that the public health department should be asked.
Do health officials expect to see a rise in COVID-19 cases linked to gatherings around the Christmas holiday?
Well, we hope not, but we know that there will be some gatherings. So the question is, how much are we going to see? So hopefully people followed advice, stayed at home, we're able to socially distant, all of those things. And so I'm hopeful that we won't see a huge spike, but we'll wait and see.
Thank you for joining us for the St. Louis